Hi, so another Mrs. H Psychology revision video for AQA Psychology, Paper 3, Schizophrenia, specifically this one on reliability and validity for schizophrenia. So I had some feedback, somebody suggesting to try it with PowerPoint, so hopefully this you find a little bit better. Right, so let's get going with this. Okay, so this is the question. Briefly discuss why reliability and validity are issues in diagnosis and classification of schizophrenia. It is from a past sample paper from AQA. So what do we need to know? Right, reliability. Let's use key terms. Reliability is consistency. In other words, in this case, is a diagnosis consistent, for example, by the same clinician? That would be test, retest over time. Okay, different times, so same clinician over different times, that was test, retest, or by different clinicians at the same time, and we would call that inter-rater. And a kappa score of 0.8 or above is generally considered good and reliable. So the diagnostic tools that are used are currently ICD and DSM, but the problem is that reliability seems very low with these. So, for example, Chenot had two psychiatrists diagnose 100 patients using both DSM and ICD and found that the inter-rater diagnostics was poor. For example, one diagnosed 26 patients with schizophrenia using the DSM, but 44 using the ICD. And the other clinician diagnosed 13 using the DSM and 24 using ICD, and obviously that's showing very poor reliability. Reed et al., 1970, 194 British and 134 US psychiatrists used a case study, same case study, to provide a diagnosis of one patient. In fact, they found that 69% of the US, but only 2% of the UK psychiatrists actually went on to diagnose schizophrenia, obviously showing reliability to be very poor. So let's move on to validity. Okay, so validity, we need to define it. It's accuracy. That's what we mean by it. Does it test what it claims to test? So you should be saying valid, i.e. accurate. Does it test what it claims to test? So here, are we really diagnosing schizophrenia with unique characteristics, or are we in fact diagnosing something else? So we might use criterion validity, so you need to name that. In other words, using different assessment systems, and they should conclude the same results. But as we've seen from above, research shows that schizophrenia is more likely diagnosed with ICD than DSM, suggesting either an overdiagnosis in the ICD use or underdiagnosis with DSM. And obviously, given that it's a very serious diagnostic or diagnosis for a patient to have, that's not going to be good. You can also use the Rosenhan study. We know that's, there's a lot of descriptive material on that, so be very careful. You need just a tiny, tiny bit. So, for example, maybe say he found that 8 normal, in inverted commas, people could get themselves admitted to a mental hospital as a schizophrenic patient merely by claiming to hear voices and hearing words like hollow and thud. And Rosenhan also went on to find that staff at a hospital, when they were told to expect pseudo patients, so people who were pretending to be schizophrenic, they suspected 83 out of 193 genuine patients of being fake. Okay, all of the patients were actually genuine. So basically, this is showing that reliability and validity of diagnosis is really not as it should be. So we also would want to include comorbidity. Okay, what do we mean by comorbidity? It refers to the extent that 2 or more conditions can occur at the same time. So, for example, patients with schizophrenia also very often have other conditions like substance abuse, anxiety, depression, and PTSD. Okay, so examples of this, Buckley, a researcher, believes that approximately 50% of schizophrenic patients also have a diagnosis of clinical depression, and also 47% are comorbid for substance abuse. So an example to just help understand this a little bit more, schizophrenia and OCD often, well, first of all, they are 2 very distinct psychiatric conditions. and roughly 1% of the population develop schizophrenia, and roughly 2 to 3% of the population develop OCD. Now, both of those are obviously fairly rare, so we would expect that only a few people with schizophrenia would also go on to develop OCD and vice versa. However, evidence shows that those two conditions appear quite often together, and that means it's actually more than chance would suggest, okay, which is a little bit unusual and therefore questionable. The problem with this is if they occur together a lot, perhaps we're looking at a completely separate illness, and maybe we're not diagnosing schizophrenia as we think we are. And obviously that would really question the validity of it. Another example, if half the schizophrenic patients are also diagnosed with clinical depression, then maybe we're just quite bad at telling the difference between the two conditions. It may be that very severe depression looks a lot like schizophrenia and vice versa. So maybe they are just one condition, but the picture is very confusing. And obviously it's showing that there's a weakness really in the diagnosis and classification of schizophrenia. Going on, symptom overlap. What do we mean by this? Symptoms of one illness also occur as symptoms for other illnesses. For example, symptoms of clinical depression, as we've said, are also found in schizophrenia. So it is difficult for a practitioner to decide which disorder someone is suffering from. Reid, for example, says that most schizophrenic patients have enough symptoms of other disorders, so they could also receive at least one other diagnosis. Ellison and Ross said, 1995, said people with dissociative identity disorder actually have more schizophrenic symptoms than people diagnosed as being schizophrenic. Okay, so why is this a problem? Again, we may find it difficult to diagnose the actual illness someone has, and we may clinicians may diagnose something else. If it's not a correct diagnosis, then obviously those patients are not getting the correct help they need and treatment. So their prognosis for the future is not going to be good. Also, it means a potential wasted cost to the economy as well, as treatment will be wasted if it's incorrect, and it may even cause more harm. Gender bias, next one. Is there a genuine gender difference in development and classification and diagnosis of schizophrenia, or is there a tendency to over or under-diagnose people depending on their sex, which would be the gender bias? So Longnecker, for example, reviewed research and found that since 1980, males were diagnosed more than females. The question is this because there are genuinely more males with schizophrenia, or becoming more males with schizophrenia, or is it that clinicians are making the wrong diagnosis? So Loring and Powell selected 290 male and female psychiatrists to read case studies of patients' behaviour and make a judgment on these people using standardised diagnostic criteria like the DSM. And when the patients were described as male or no information about gender was given, 56% of the psychiatrists diagnosed schizophrenia. But when the patients were described as female, so this is the same patients, only 20% were diagnosed with schizophrenia. So what's also interesting to note is that the gender bias was not as evident among the female psychiatrists, suggesting that the diagnosis is influenced not only by the gender of the patient, but also the gender of the clinician. And we see with this research, with Loring and Powell's research, we see a clear gender bias going on. So why on earth is that happening? So Cotton found participants typically function better, found female participants, female patients even, typically function better. For example, their interpersonal skills are better than males. And then maybe that is why this explanation was perhaps the reason they don't get diagnosed as often is that their symptoms don't seem so extreme, or they seem to be coping better with their symptoms, and therefore they're not diagnosed, rather than it being that more males are actually developing schizophrenia. Now, the problem with this is potentially it means that obviously incorrect information is available and being published, but also maybe those patients may be getting the wrong diagnosis or no diagnosis, and therefore either the no treatment or the wrong treatment, and that will really impact on their futures and their success rates. Cultural bias. There is a tendency to overdiagnose members of other cultures as suffering from schizophrenia. So, for example, the 1% is saying that the general incidence of schizophrenia in the West Indies and in the UK is 1%. However, Afro-Caribbeans are 7 times more likely to be diagnosed with schizophrenia when they're living in the UK. This suggests either there's something about for those people living in the UK is causing them to a load more of them to develop schizophrenia, or there is a misdiagnosis of schizophrenia. Okay, and also just going on, cultural bias, evaluation. So with our evaluation, we need to include a bit of evaluation of these. So what's great about having ICD and DSM is it does allow practitioners to at least have a common assessment tool, okay, that they can use the same common language to do assessments. So that's a very positive thing. And also reliability does seem to be increasing with each update of the DSM. So, for example, Beck, 1962, diagnosis for 153 patients was only 54%, but Soderberg in 2005 found this had increased up to 81% using the DSM. So that's a very positive thing. However, DSM does seem to be more reliable than the ICD, as symptoms are more specifically outlined, and yet the ICD is still being used. Closter-Cutter also assessed 489 admissions to psychiatric wards, and he found that positive symptoms were more useful for diagnosis than negative symptoms of schizophrenia. So there does seem to be an issue over which symptoms are used to assess them. And despite the claims for increased reliability in the more recent editions of DSM, the DSM we're seeing is still not very reliable, and it doesn't seem to be particularly valid either. So hopefully that has been useful for you. I would say that you don't need, it depends on the number of marks. If it's a 16 marker, you can pop all of that in. If it's just the sample 8 marker that was on the sample paper, then obviously you need to reduce that down. I hope that was useful for you. Please like it. It does give me a bit of feedback, and please do subscribe because that's also useful feedback for me. And it means that it will encourage me to make some more videos to help you. So hopefully that is useful for you.